Now we move to our live case. That is our third live case from Delhi by renowned Professor Ashok Sheth.
Okay, great. It's a pleasure to be here amongst you all. Uh, Can we just go, Elio? So let me just show you, present to you my colleagues, Dr. Vijay, Dr. Vishal is with me. You know them both very well. They're experts in their own right in interventional cardiology and mechanical circulatory support. And I have with me our intervention fellow, Dr. Avinash. And of course, our team, then there's Dr. Nishit Chandra, who's our head of imaging, Director, Interventional Cardiology and Head of Imaging. And we're going to present to you an interesting case. We have, of course, our fellow from Bangladesh, Iqbal is here, and of course, our support techs. So we're going to show you this, we have this 50-year-old gentleman who has worsening angina over a period of last a year. He did have an exercise thallium scan which showed ischemia, but has been getting worse over the last 6 months. And therefore, he came to us for an angiogram which has demonstrated triple vessel disease on a normal LV function. So let's just now see his angiogram and then we can discuss what we do. So can we just have his angiogram, please? So that's his left system. You can see that there's some calcification in the circumflex, but a high-grade stenosis in the circumflex. You have next, in the AP cranial projection, you have that LAD. The first bifurcation is an LAD septal bifurcation, a large septal. There's enough calcification which is quite clearly visible. The second stenosis is at the second diagonal bifurcation. And the proximal LAD has clear calcification right up to the mid-segment. We can see that in the ariocaudal. Can we just see in the ariocaudal projection? And that's quite visible here. That's a very big chunk of eccentric calcification as is seen in this ario projection. Next. 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 You can see that again in this view, both the circumflex stenosis as well as the LAD bifurcations. Next. There's some osteal disease as well. I think that was seen in the osteal LAD disease. That was seen well on the previous iliocaudal projection. Let's go to the iliocaudal, the previous one. And you can see that osteal disease looks 50%. Doesn't look critical, but we'll know that very soon. And let's go to the right coronary artery. And the RCA has a very large PDA with a high-grade stenosis. The syntax score is 26. And the syntax 2, MACE for CABG 6.8 and for PCI 4.8 at 5 years. So over to you for this discussion.
So, sir, it looks multivessel disease and double bifurcation. So, any comment from our panel? Professor Fazilatur Malik, would you like to make any comment?
Anji? Hanji? हाँ ये तो चला जाएगा. Sister, can you give him MS?
Good afternoon, and it's very nice to see you do a case, and we are super excited to see how it proceeds. So we've got a patient who has essentially multivessel disease, and the lesions tend to be very tight, and there's some degree of slow flow as well, pretty complex anatomy, and I see that you've already wired the circ.
We actually started, Fazila, good to hear you, and wonderful to have the first comments from you. We started the case early because we were...
Of course, I mean, that's how life cases go. You have to start early. Totally agree. So the thing is, would you care to tell us your strategy, or will you want us to guess?
So no, I don't think I want you to guess, because I guess everybody will have similar strategies, but I think it's more a point of discussion once I've set the strategy. So We decided, of course, that the PDA needs to support the left system. When we do it, it's a discrete lesion, so we went ahead and stented the PDA. That was straightforward, and you just have a look at that. That's a wire there. Next, dilated with a 2.5 NC to full 20 atmospheres, and then stented with a 2.75 into 12. And we got that, and the final result is what you will see. Post-dilated with a 3 in its proximal part where the lesion was, and that was the final result on that PDA. You can see that we've really overgrown ourselves. There is some plaque which we have sort of at the distal part of that, but we've not disturbed that plaque. And let's hope we haven't landed in a major plaque burden, but it seems it's fine, and the lesion's well opened, and the vessel is clearly large. Having satisfied ourselves, we went to the circumflex because we felt again that was a discrete lesion, and it provides a support when we do the LED, and therefore we actually went to the circumflex, and that's why you see the wire in the circumflex. We went ahead and again dilated that with a 3, and then we have now implanted a 3 stent which has been post-dilated to 3.5. We there at this time is when we now came on so that we could show you the LED diagonal calcific bifurcation, but we also would like to see this on the OCT. That's the final result on the SIR.
Yes, my name is Dr. Ali from Istanbul, Turkey. Very nice job for the CIRC and RCA, but I'm curious about the strategy for there's a true and complex bifurcation lesion in the LED, mostly for the diagonal separates in itself as a bifurcation. I'm curious about about your strategy on this bifurcation lesion.
Welcome, Dr. Ashok Sheth from Bangladesh Society of Cardiovascular Intervention, Dhaka. And we are seeing your case. Practically, it's a complex multivessel disease. And you have done RCA, you have done left circumflex. Now you are going with, I was from OCT, yes, OCT, LCX OCT. You want to see whether the stent is well inflated as well as the ostium of the left circumflex or proximal part. What is your idea for doing OCT for left circumflex, Dr. Sheth?
So how does it look, Nishit?
Yes, sir.
Yes, we are hearing you.
Oh, good, good.
So
So yes,
it's well expanded. No
so
medial
Nishit is now going to actually talk to you about the OCT. The OCT assessment was done for the stent itself, optimization. And that is why
Stent
we did this
optimization, yes.
OCT, because we're going to use OCT for LED as well.
So if you can see the OCT, and it was done post-procedure, post-implantation of three stent and post-dilated to 3.5 in the mid, very tight circumflex. So if you see the distal edge is excellent. You can, there is no medial dissection, is well opposed, and the lumen area is 6.5, the MSA, at 6.5. As we go more proximally, you can see that the stent is absolutely opposed, and there is, at the tightest point where the stenosis was, the expansion is 79%. It's close to 80%. So we may go up a bit, but 80% is also acceptable in number of trials. 80% was also the limit. The proximal edge is also well expanded. There are some hanging struts. You can see malposition on the proximal edge, but proximal edge malposition can be left because they are not related with MACE. What it basically does is the subsequent procedure, the wire may go under it, but we may go up and with a size of what?
So the reason for that is, if you saw, is that there is, can you go back on the previous angiographic shot? And you will see on the previous angiographic shot that there's a dilated area that's slightly over dilated, or yeah, this is fine. This is fine. Please, just show the angiogram. You see that dilated portion in the proximal segment. that is ectatic area. That's where some malapposition is seen. Next. And you can see that that may be very difficult to oppose completely, but I don't think it has any consequences next. But we will definitely, by what Nishit Chandra has said, we'll go in with our 3.5 and go up to higher pressures to get a better expansion at that tightest point, which was the calcified point. Next. And you will see that next, and you will actually see a shot here, and you can see that's the dilated area where you see some malapposition. But we're more concerned about that lesion point, which if it's not achieved, the full expansion can be at least had a full expansion. So Nishit, what was the stent area at that point, just at the tightest point? Yeah, somewhere there.
So the stent MSA at that area is 5.18.
See, so that's just about, according to the distal where we actually got a 6.5. That's why Nishit said it was a 79% expansion. Yeah, we could do higher pressures there, and that's about it. And I know that we'll just get a better expansion, both of the frames, and then we'll move to the LAD, which is really the clear point of interest. So let's go to the LAO projection so that I can just see that we're the proximal struts and then do whatever is needed. Yeah. So we don't need to go anywhere else apart from the proximal struts. And don't move it, please, LAO, and let's go up. Just a moment, just a moment, just a moment. Yeah, go up. Yeah, 10, 12. Give me a caudal. 14, 16. Caudal, LAO may, please. LAO, 16, 18, 22, 24. So that's 24. I think we would have got our results out of this deflate. Okay, we'll just take our shot. Okay. So I think, yeah. So I think we've done, I'm sure we would have improved on that, so there's no point going back. We would have probably got 85% close to that, and that is good. So let's now move to the LAD. And you wanted our strategy on the LAD. So let's look at the LAD.
Your LED has double bifurcation involving the
Yes, it
ostium
has.
of the LED.
So we're going to image the whole thing after a pre-dilatation and then decide the strategy, but it's a double bifurcation, so we clear that we're going to use a strategy which is going to deal with the distal bifurcation and the proximal bifurcation. Let's study it with IVUS and decide our tools that we want to use. And also assess the ostia of the LAD. For me, it would be using, doing it as two separate bifurcations, deal with the distal bifurcation first and then the proximal bifurcation. They both seem to be different in nature. The proximal seems to be more heavily calcified. Can I just have a test on that? And I'll see whether this wire needs to be changed to go down that. Sure. Yeah, that's the diagonal. The curve may need to be changed, you know? No, it's gone. So I'm going to dilate that. I'm going to have a second wire and side, okay. That's a big branch, you know? You can actually put it down here. Okay. Let's have a second wire. Run through. So we'll have a run through extra floppy into that second diagonal. So we're going to dilate the first branch, first bifurcation, dilate the second bifurcation, do an OCT, and then study adjunctive devices. But adjunctive devices, I feel, for the distal may just be balloon. For the proximal bifurcation, it could be IVL. So let's just look at it. And we know that the vessel tapers, so not the same IVL can be used for distal and proximal. So it's going to be interesting to see how we strategize based on our imaging. Any comments from your end? I think we lost them.
No, we have, so it's a really pretty complex situation there. So you've got an ostial LED and you've got a large size diagonal, very diseased, and it's a Medina 111. So it's, I think imaging could really guide
Pardon.
us in deciding what to do and what not to do, because in the osteo of the LED we don't see any landing zone. So do we go into the left main, and if so, how much? And what about the diagonal and LED? Do we do a double stent strategy? And if that, what about going from LED to diagonal and doing another for the LED? Is that an option?
So we may need to dilate that proximal segment a bit more to
Yeah,
even get
to
a wire.
Yes, to get a clearer picture. And then
Yeah.
you will take your OCT. Once you've pre-dilated,
Correct.
then the OCT will go easily and we can get an idea of
Better,
what
better
entails.
picture of everything. Go next. And I think, that 2 millimeter NC balloon will do a job enough for us to start understanding our steps. I'm not so worried about this first bifurcation. I want to get into the second one because that's very tight. As you saw, the second bifurcation is very tight. It has at its origin quite a severe stenosis. And if we dilate it, we don't want to lose that big branch, which is quite clear. So we will get our wire down and then dilate and then OCT. And I think we would then be clearly doing what is necessary. If you see, even angiographically, the proximal bifurcation is the very heavily calcified bifurcation. Go cranial. Clearly requires a calcium modification, there's no doubt. Okay, now let's see. The good part is that everything follows the wires. Yeah, that's okay.
I think
You know,
I think both bifurcations contains lots of calcium, and both of them are narrowed angle bifurcations. I think these features are defined in the definition trial as the criteria which increases the risk of losing the side branch if we use a provisional strategy. So if we decide how we further implement a strategy
I could have
in
a
these
third wire.
lesions, I think an upfront
I could have a third wire.
two-stent strategy will be more
Third wire.
applicable for these bifurcation lesions, I guess.
third wire. Third wire. Anji? पैर नहीं हिलाइए थोड़े थोड़े बस. So we're going to put a third wire down into the septal. ये run through. तीसरा डाल गए, दो डाल गए. MS or midazolam 2 milligrams. So we're now putting a third wire down. नहीं अब पता चलना भी नहीं चाहिए. देखा. Okay, have we got our balloons? What have we got? 2 NC.
So any thoughts from our other chairpersons and panel? Please feel free to.
What he is doing now, that he has wired both the vessels, LED and distal bifurcation, and after pre-dilatation, both proximal lesion as well as distal lesion, doing OCT, then we have to decide most likely.
Okay, can I just center it so that RA Caudal?
Most likely distal one may require double stent strategy, and proximal one may be done with drag balloon for the bifurcation branch, and then stenting from LED
Go cranial.
may require up to LM, according to the result of OCT findings. Third wire. Your guide catheter is
wire.
7 probably, most likely 7. Harvest.
It's interesting how these wires track nicely first, and then I think it's just change of the curves.
Yes.
Oh, yeah, they're just direction
small
is
ones.
slightly different.
Now you are proceeding to septal.
Yeah,
Yes.
that's it, good enough. Now you could go to,
The septal is also like LED. Big
So
vessel
still-
with bifurcation.
Actually, what he is doing,
Yes, for a- for a
he's
compound
called for final call for planning. Wiring
Okay.
all the vessels,
Yes.
then go for pre-deal, then OCT run. That will guide the further strategy.
Then decide
okay,
how many stand and in what technique and from where to where he will place distal stand with
Vijay,
side brass
don't take that
and
out because
proximal stand
we
with
need to
left
mark
main.
that with something.
Dr. Sheth, actually what colleague raised the question, according to definition to criteria, it seems to be narrow angle, true bifurcation lesion. Can you hear us?
I can hear you.
Yes.
Which
Dr.
wires,
Khalid,
which?
Ali Nawaz
We got
Khalid
two wires
raised the
on the top.
question,
Vijay, can we just have
his
to make
point
sure
of
that
view,
the
he
two wires
choose
stay at
first
the bottom,
upfront double
that
distance
wire
strategy.
at the bottom,
Right?
and
Khalid?
only the left.
Yes. So actually, still, Dr. Sheth is planning to do actually what will be the best for our patient, whether it is go for
Huh?
provisional or a really
This is diagonal,
patient
so
need
put this at the
upfront
bottom
double
on the
distance
other side.
strategy. Still, he is planning.
Yeah, that's right. So, okay. Get me the 2 mm balloon.
So what size balloon you are considering this case?
That was wire is awkward. Yeah. Okay. So it's a 2 mm non-compliant balloon to open up all these two bifurcations.
So what is the size of balloon?
2 mm at the moment. So what, Vijay, what are you? Yeah. Yeah, put a wire introducer on that, the second diagonal. No, don't do too many things. Somebody else will do that. Okay. So here is my balloon. You can leave the wires. Okay, go up 10. Okay, you want me to do the next one? Okay, go up 10, 12, 14, 18, deflate. 18, deflate. See, this is expanding, though it's an undersized balloon, but it's expanding, so that's okay. 18. Okay, deflate. And let's now treat the proximal part also. Go up 18, 20, 24. Deflate. Now we'll do the OCT. We also want to give some nitro, improve the flow, give some diltiazem, and then work at it. Okay? Show the pressures. Yeah, okay. What's the ACT? What do they say the ACT? Yeah, but give 3,000 more anyway. Okay. Let's give OCT here. So, you know, I still believe that my first diagonal could be provisional because it's just some osteal disease that doesn't extend too far down. You can see that it's a small vessel, not a large vessel. It's not something that I'm looking at doing a two-stent strategy on. So I'm very clear that that's a provisional one for me. And we might do a kissing at the end, but it's still provisional. As far as the proximal one's concerned, that's also going to be provisional. Vijay, can you hold on to this? And because that's a septal and we want to keep the septal open.
So all through you are planning to go for provisional.
Absolutely. And do it in two halves. Do the first. It's not a single stent going from the distal to the proximal. It's going to be first dealing with the second bifurcation with a stent across, and then dealing with my first bifurcation. Not crossing, as you can see. So we'll have to 2.5 NC. That will help us to cross. Okay. It just shows that that lesion proximally is far more severe than the distal. And the distal one was, but after the 2 millimeter balloon dilatation, you should see what it looks like. If we do the distal one first, it just gets all these wires out, and then we're just left with 2 wires. You'll have to take this air out, Vijay. We give nitro and want to see how big the vessel sizes are, and that's what we have. That angle in the first one is quite big. You can see the difference between the diagonal and the main LAD. You can see that it's quite a large vessel, the main LED, but the diagonal isn't. Should we go little LAO in its cranial? Bus. So now let me have a 2.5 balloon. So you can see that my the LAD at the second bifurcation doesn't need any plaque modification. It's already opening up well. Just hold it firmly. And I'm going to therefore treat it accordingly. See, now this is more related to angle and also wire intertwining. So I'm going to take this, the septal wire out for the moment and then go ahead with whatever we have to do and go up here. Well, we'll take it. Okay, go ahead here. 10, 12, 14, 18, 20, 24. This is the point which is going to require 26, 28. Saw that? This is the point which is going to require deflate. This is going to require clearly an IVL. And now coming to the next part of it. Get me another balloon. There it is. Okay, go up 10, 12, 14. See, this expands well, deflate. 10, 12, 14. Deflate. 10, 12, 14, 18. Deflate. So now I'm going to go in with an IVL and go up 18. 18. Yeah, deflate. But OCT will not go. I personally think, okay, we'll see whether we can get an OCT down. Yeah, but it still didn't open up. You saw that. Did you see, guys, that it didn't open up? The proximal one? Did you see that?
We are not seeing.
We did, and in this heavily calcified vessel, do you think for imaging an IVUS would be easier to negotiate?
Not, Fazila, I find IVUS more difficult to negotiate multiple times, primarily just because it's in fact far more difficult as it comes around corners, that its forward push just gets very diminished. I think it's that angle which is important. I'm going to actually, because we're using IVUS, will continue. Otherwise, we know what it is. We know that it will require IVL. You saw just the way it hasn't expanded that it will require IVL. So it's not as if it's rocket science here to guide us what to do. That's an IVL lesion. More rocket science would be what do you do for the distal, which is dilating well, and I'm therefore very clear that that for me is a provisional strategy. Let's see if this goes at this stage, OCT. Otherwise, my strategies are clear. I will need to do an IVL even to get my stent down. See, it doesn't.
Your balloons opened well. That's good. So now,
Yeah.
yeah, and your
My distal.
OCT seems to be.
So, so here is the IVL issue, okay? Get me the IVL, a 3 millimeter IVL. So I'm taking the, to avoid intertwining, which we have here. Yes, yeah, but the stent won't may not go across the distal region. Vijay, just a moment. Let's just make sure that
how's the balloon behaving? Is it going down easily?
what? Absolutely. That's what I'm going to. No, don't go. No. Yes, I'm just going to see which is the septal wire. Okay. Then take it out. Sorry, what were you saying? What were you saying,
You
Fazla?
lose your wire in the septal.
I was asking, how is your balloon going down? You're planning to
My
take an IVL.
Yeah, my balloon can go down with some degree of difficulty, but my stent won't go down. I'm quite sure of that. It's an angle there. Unless we break that angle, the stent won't go down. Okay. See that diagonal? So I need to now dilate that diagonal. So can I have a 2 millimeter balloon to dilate that diagonal? And I'm going to do an IVL prior to putting the distal stent in, okay? So can I have the 2 millimeter balloon for that diagonal? You can see that my LED dilates well. So I would need a 30, 2.5 into 30 onyx for the distal LED. Okay, just hold this there. So this is now a low pressure to the diagonal, which you know is 90, is already closing because of the high pressure dilatations on the LED. And you'll see that the balloon goes down fine. Okay. Go up, 2, 4, plus. So that's 4 atmospheres in furniture, you know? Okay. Deflate.
Dr. Sheth. Hello? Dr.
Okay.
Sheth,
Yep.
are you hearing?
I'm hearing you very well.
Okay. For a bifurcation lesion, if I want to leave the diagonal or branch, then usually we do not predilate the diagonal. But what is your
You're
idea
absolutely right.
regarding this predilatation?
So if you see this, my idea is exactly the same. Can you give me some saline? My exactly the same. The only advantage of predilatation is avoidance of closure, and in this case,
Yes.
as you can see, it's already closed. It's 99% already. So it just gets it open. On the other hand, it's a low pressure predilatation so that you don't dissect the vessel, because crossing it becomes much more difficult after that.
Have you
So-
used here a DCB for diagonal?
No,
Have
no,
you
it was just balloon and low pressure balloon dilatation to open up the diagonal.
Yes,
So
low
that
pressure balloon to just open up the diagonal to
so it was
avoid
95%, and you can see that it's now nicely open. I can show you.
avoid
not-
closing of the
it's not
diagonal
open.
after stent.
And before this, if you saw, it was closed. Okay, and now we actually want to do my IVL.
IVL.
I would have finished it with a stent first, but I don't think my stent's going to go through, so I'm going to finish with the IVL first to the proximal bifurcation, and then work on my distal bifurcation to stent it. And that would still remain a provisional stent, a 3 millimeter IVL.
You will not do imaging now?
No, I don't see any point of imaging. You saw my catheter doesn't go through. I actually know that we've got to do an IVL. Our balloons were inflating well, and I always say that balloon should inflate well in 2 orthogonal projections. Then we know that we've actually treated the lesion. Our distal balloons were fine. The proximal balloon did not inflate at the proximal bifurcation, so it's an IVL. So we must understand why we're using imaging. Once we know the strategy, then using an imaging is unnecessary at this point, where we're not being able to get imaging capture. For me, to get the imaging capture across, just to guide me, we know it's a 3 millimeter vessel. We know IVL is the best solution for this.
Dr. Ashok is
Our recorder.
Dr. Sophia here.
Hello, Sophia.
Yeah, you're doing well. One thing I know, you are very expert and you have got all the confidence in the world. But here we have got the juniors and they are also started the IVAS.
Cranial.
Here they want to learn and see your expert way of dealing with it. That's why we are
Right.
repeatedly
Okay.
telling you that, okay?
Right,
So
right,
that will
of
help
course.
us here.
So look at the rock here. Even the IVL has a difficulty in crossing that rock.
Dr. Sheth, I know that in Southeast Asia you have one of the largest series of IVL. How often
Yes.
you do IVL without imaging?
Oh,
How often?
quite often. Let's see where we are, and then I'm going to, yeah, go on. I could predilate with a 3 and then do it. Show me.
We have seen that you do IVL, you do rotatripsy, at
Yeah.
least 1 year ago I have seen. And in Gypsy too, you have already also shown very nicely.
So I think we'll have to dilate it with a 3 before we even get this IVL in. And we may also use a guide liner to get it in. Thank you. We may also use a guide liner to get it in. So let's have a guide extension catheter and my 3 IVL. See, if I can't get the IVL across the lesion, you can imagine that I was correct. I would not get a stent. So we're going to have a guide extension, and we'll have a 3 NC NY balloon. Okay? So yes, your question about IVL. See, we got to make algorithms simple. Don't get lost in imaging. Use imaging for the sake that it is, that it guides you about treatment strategies, not in all cases, in some cases, and it definitely helps you with optimization in most complex cases. It also guides you when you need to use ultra high pressure balloons like OPN, etc. Yeah, guide liner first. So when, and in
Sir.
25% cases, just a
Sir,
moment.
can you hear me, sir? Me, Amal.
I can hear you. So firstly, let me tell you my algorithm. So in most instances of severely calcified lesions,
Sir, is there any role of imaging to select whether rota or IVL will do work better?
I'll tell you. Yes, it will still work. Vishal, it will go through. If it's a 7 French, this will go on the side. The NY does. Sorry, say that again. Were you saying something?
Sir.
Hmm?
Sir, can you
Pass that through.
can you hear me, sir?
Yes, I can hear you.
Yeah. So the imaging modalities
Yeah.
like IBAS, is there any role to select the calcium modification?
yes.
Rota or IVL we can use? Which one
yes,
is
I think-
preferable?
See,
Which one
in
will
a sense,
act good?
can I just answer that? You are right about, firstly, of course, 270 to 360 degree calcification is what is needed for IVL to work best. The greater the arc of the calcium, the IVL works better. The lesser the arc of the calcium, the IVL works less well. And that's because there's dissipation of all the impulses. On the other hand, we also know that the same is the criteria for even for our rota. The simple facts of life are that eccentric lesions, calcified nodules may be better off with rotational atherectomy first or orbital atherectomy followed by IVL, may be benefited by just rota alone, but my simple philosophy is smaller vessels, rotablator may be, and rotational atherectomy may be adequate. For larger vessels with deep calcium, IVL is the best. So vessel size actually affects your choice of treatment options as well. Let's go up here. 2, 4, 6, 8, 10, 12, 14, 18, 20, 24. Look at that rock. 26, 27. Deflate. So I'm going to now get my guide liner in because we're definitely going to need a guide liner to start delivering it. Go up 10. Okay. Negative. I think we're now going to get perfusion. This is. So we are seeing a lot of ischemia, as you know, but we have to break the lesion. And now the lesion is opening up. You saw the last image? You saw the last image? So we let him perfuse. But we just managed to open the lesion in the second pulses, and we'll deliver all our pulses here. Okay? So we'll let him breathe and go up.
This is your IVL balloon.
Yes.
And IVL
I'm
balloon
giving
you have crossed with
second.
guide extension catheter.
Yes, we've broken the lesion by the second 20 pulses at the moment. That's why you're seeing this. Now it's better open. You see that?
Yes, we are seeing balloon is open almost, but still seems to be dog boning.
Yeah, but it's still better than before. 6.
Better than before, yes.
Negative. If you see the previous 2 shots, and let me show you the previous 2 shots. Minus. This is, go minus. Next. This is how we got that in. This was the first sort of impulses, the first cycle. You can see that it was clearly dog boned completely. Next.
Right.
And then this is my second pulses, second 10. And you can see that at the end of the second, we would see it slightly open up. And he was by this time having next. He started getting VT. And now we've opened it up, so that's why he's much more stable. Okay, we'll just bring it back slightly. Can I go to the RAO caudal projection? Always look at the IVL in 2 different projections. It's okay. Okay, go up. We'll go up again and we'll deliver every pulse just here. 6. That's the chunk. You see that?
Yes.
So we'll deliver all our pulses here. 6. Negative. So yes, you were asking about IVL. Smaller vessels, less than 3, 2.75 and less, you can have adequate calcium ablation by rotational atherectomy or orbital. Large vessels, you would need high-speed orbital atherectomy or IVL to take away deep calcium. In eccentric lesions in large vessels, I would use rotational atherectomy to take away superficial calcification and then work on the deep calcification with IVL. But the final answer to your any method you use is complete dilatation using a non-compliant balloon after plaque modification in 2 orthogonal projections. 1 is to 1 balloon. If it expands completely, you then are ready to stent. If it doesn't expand completely in 2 orthogonal projections, you need further plaque modification. Go up. So for me, it's not the imaging post-atherectomy. For final optimization, it's clearly imaging. For post-atherectomy or IVL, it is 1 is to 1 balloon expansion in 2 orthogonal projections is the biggest criteria. Six, negative, go cranial. बस हो गया. वहाँ पे तो सब ठीक है.
So, sir, you are in the middle of the battle.
Yeah, I from normally position it slightly eccentric. You see that marker, that first marker should be at the point of maximum calcification. Go on. That's right. And that's where it is.
Dr.
So
Sheth,
that's where
Sir,
I'm delivering it.
let me say something, sir, regarding our total program. You please
Last
keep
shot.
continue. Keep
Yeah, I will.
continue. We will
And you
back
carry
again
on and I'll
to
show you
catch you.
Last shot.
Sir, and just tell me before going to our session, but
go
you
on,
just
tell
tell me what is your next
One,
plan.
3, 4. Okay.
Dr. Sheth,
My next plan would be to do the distal lesion now, the bifurcation, and then dilate this completely with an NC balloon, maybe an OPN balloon, and then, you know, and remember we should deflate. Remember we should also look at the ostia, so we'll look at the ostia with imaging after I've done my distal implantation.
and Dr. Sheth, your case is enjoying by your up to the third generation of your disciples. I am your second generation, and my fellows are also present here, including my teachers also. And so you are showing your charismatic case, including your third generation of the disciples. It's our credit. We are grateful to you that still we are getting you in the midst of us in our clinical meeting, in our conference, and you are showing excellent case.
Hello. Can you hear me, sir? Ashok, sir?
Yes, I can hear you.
Okay, can we see the last result of your case?
That's right. That's right.
Me,
So I'm
Dr.
going to
Amol,
talk
sir.
to you now. We are shifting the patient, so we're right in the middle of that. Let's just show you the last. Where is Kaun idhar aao? Idhar aao. Go back to where we. Ek minute. If you give me just 3 minutes for the patient to shift, we'll come back to you. But it's interesting. It's interesting, and so it's important for you to see it. Yeah. Let's go to. नहीं, ये नहीं, यहाँ पे चलो छोड़ो.
Sir, you just demonstrate us.
I will. It's just. ये कहाँ पहुँच गया यार? Left system. जहाँ पे वो
It is right, already done.
पीछे जाने के पर you just दिमाग तो ये left system में हमने उनको दिखा दिया था. We'd shown them the IVL. करो ना. I was just showing it to you. Just prop him up and give him the medicines there. Prop up करके. So we're going to take you to that. Can we just go back? I can talk to you, and you can you see the fluoro? Can you see the fluoro?
Yes, sir.
Okay, then let me just talk to you. Can we just keep going back? So what had happened was, and you can see the fluoro? So
Yes, sir.
we decided that, and I'll take you to the IVL because that was the important part of it. And so I took you to the IVL, and this is where we left you.
Yes,
80 pulses were delivered here, as you can see. This is highly constricted. After the first 20 pulses, it partially opened up. The patient was getting very ischemic at this stage because it wasn't opening up, and he did have VT, but it was luckily with his hemodynamics okay. And so we continued on till we actually opened the lesion. And this is looking at, always important to look at the IVL balloon in 2 orthogonal projections to understand whether it's implanted or not, expanded or not, and it's not in this view. So we delivered our all 80 pulses here. And you can see in the cranial view it looks expanded. We then had lost the septal, as you can see. That caused him to be really ischemic and very uncomfortable with a lot of chest pain. So our next thing was to recross into that septal and get it back flowing. Once we recrossed into the septal and got it flowing, then we wanted to finish the job on the LAD diagonal D2 bifurcation. So here's the stent, which is an onyx into the distal vessel and implanted and then taken up to 18 atmospheres and then post-dilated. And by this time, the diagonal too had also closed up, obviously with high pressure dilatations, and he was now getting more chest pain. So we have now a recrossing of the diagonal. and we
Diagonal
were
or
able-
septal, sir, this one?
No, the septal is already crossed and dilated,
already.
so we have that flowing.
You try
Now
to-
it is the diagonal, as you can see.
Okay, sir.
And we crossed into the diagonal and got it flowing, and then did a kissing balloon with a non-compliant 2 millimeter into the diagonal. And having done that, opened the diagonal, and finally a kissing balloon. We were quite nice having reperfused the diagonal. And so a distal job was done. Now we needed to do a proximal job, which is the proximal bifurcation. You can see the diagonals flowing. You can see the distal bifurcation nicely done. So we are happy with the distal one. But you can see this septal is dissected. So we then had to sort this out. High pressure dilatations of 3 millimeters to 28 atmospheres to make sure that we cracked the lesion adequately and opened it in 2 orthogonal projections. Here we're seeing it in the other projection. And again at 28 atmospheres, just making sure that we are all done properly and nicely. You can see that we getting it into position. And then we did a mini crush to the stent, put a stent into the septal after having good adequate dilatation. We can see that we did a mini crush to that septal because it was dissected and closing up again and again. And after having crushed that with the LED stent, which you can see is adequately dilated in the REO projection and also in the LEO projection, we then went ahead and recrossed into the septal.
Excellent result, sir. Excellent
and
result,
then
but
recrossed into the septal and did a kissing here. And after having done a kissing from the septal, we actually then had, this is the kissing, the septal as well as the LED. And then we did that, and we actually had a final high pressure dilatation. There was no place for, as you know, a pot, but bring it to the ostia, and that's it. And then we did an OCT. This is the final result, as you see here. LED diagonal, nicely. The T2 has been provisional. The septal had to be stented in a mini in a mini crush technique. And the ostia we left alone. We looked at it on the OCT. It was 4 millimeters square, so we left the ostia alone. We checked the RCA because he was very uncomfortable, it's flowing beautifully. And of course, this is the areocaudal projection.
sir, any spider view, sir, to see the ostium of the LED?
This is, you can see it in
Any
this view.
yellow caudal?
You can see, this is the areocaudal. You can see that the doesn't look so bad at all. It's around 50% still, no trauma to it. And you saw it anyway in the previous, and there was enough contrast.
Sir,
just wanted to show-
initially your strategy was fixed to positional stenting. What are the factor influence you to go to the kissing balloon double LED D1 and LED septal?
Oh, the D2 was always a provisional, but the dissection of the calcified septal with a lot of ischemia and its closure, you saw that it had closed, led to the fact that it had to be stented. So that is the reason why it was stented. It's a very large septal. We could not afford to have it closed, and it had closed due to a dissection.
So just you open the proximal part of the D1 and septal. Okay, sir?
Correct.
There is no stent.
Where? Sorry, say that again.
There is no stent, sir. Only kissing balloon.
Where? In the diagonal, there is no stent. It's a kissing balloon. In the diagonal, there's no stent. In the septal, there's
Sir,
a stent.
which technique you adopted?
Oh, this is, this one was a mini crush.
Mini crush, sir. Yes.
Yeah, put the septal stent. Had to be the septal stent first, as you know, because the septal had closed and it was dissected. So it had to be septal first and LED after.
So you change your provisional to upfront two-stage strategy due to dissection of the side branch. Okay.
Dissection and
It's
closure
correct,
of
sir?
the side branch. Yes, absolutely.
Yes, yes.
Dissection and closure of the side branch, which you see right here, which you see in this projection, as you know. You saw that it had to be crossed. He was in severe problem with a lot of chest pain. And if you see here, it was just not good for him. And you see, and he was thrashing around quite a lot.
Thank you, sir. Excellent, excellent demonstration. Both the sir kissing balloon as well as upfront two-stage strategy for septal and provisional stenting for D1. And
You see that
also very,
you can
very.
see the septal here. You can see that the septal is closed here.
Yes, sir.
And he was having a lot of chest pain and angina,
Yes, sir.
and that's why we had to rewire it and then decided that this would be a two-stent strategy.
Yes, sir. Septal was completely lost, so that you recover it by
That's right.
upon
So finally
two-stage
we've
strategy.
got a good result on everything that we
Sir,
expected.
final
and I
result
think it
is
was-
excellent, sir. Final result is excellent.
Thank you. Thank you.
Thank
I
you,
think it
sir.
was a great learning experience and a great case, because I think there's only one thing I would have done differently if I had to do it again. I would have rotablated the proximal lesion followed by IVL because of its eccentricity. The way you saw it, it was nodular calcium. Rotational atherectomy would have actually helped to get even a much better result on that with easy rather than. So whenever I think we should see something like this, rotational plus IVL perhaps gives better results because of grooving, at least grooving of that eccentric plaque, which helps IVL get closer to the deep calcium and track it. I think both have to be used as complementary.
So, sir, let me summarize the session, sir. So, at this point, you just give a 1 minute's conclusion for our audience.
Yeah, my conclusion is that, you have to understand heavily calcified lesions. You have to strategize appropriately and, of course, change your strategies according to how things develop. Provisional strategy for bifurcation is a must, but bailout strategies have to be well understood. And finally, optimization of calcified lesions through imaging is of utmost importance, and that's why we still did a final OCT. As you saw, the final OCT was done, even though during the procedure we couldn't do any OCT. We still did a final OCT to make sure our edges were good, that we had no proximal dissections, and that this is the OCT. In fact, I think the next one is the OCT, that we actually had a very satisfactory MSAs throughout with the good patency of the vessel and no dissections at the edges. So optimization is of utmost importance. So I hope that you can actually appreciate that, and I thank you all for actually staying with this case.